Thank you, Deputy Jones. In the case of People versus Murray, Dr. Murray is present with counsel, Mr. Chernoff, Mr. Flanagan, Mr. Gorgian, and Mr. Pena. The people by counsel, Mr. Walgren and Ms. Brazil. All 12 jurors and the alternates are present. To everybody, good morning, and to the jurors, once again, good morning and welcome. We're going to resume with the defense presentation. Mr. Chernoff, good morning. Please call your next witness.
It's Dr. Robert Waldman, Judge.
Thank you.
Sir, please raise your right hand. Do you solemnly state that the testimony you may give in the cause now pending before this court shall be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Please be seated. Please state your name for the record. Spell your first and last names.
Dr. Robert Waldman, R-O-B-E-R-T, W-A-L-D-M-A-N.
Dr. Waldman, good morning. Let
Morning.
me provide you with introductory instructions for every witness in every case. The first of which is to please sit back and relax. The second of which is to speak in a loud voice. That way everybody can hear you. And you don't really have to bend over into the mic because it's sensitive enough. The third, if you're called upon to provide a yes or no answer to a question, answer that way rather than using slang like uh-huh or uh-uh, which can be a little tricky. And lastly, please wait until you hear an entire question before you even start to respond, even though you may think you know what the question asks. Is that all okay?
Yes.
Thank you. This will be direct examination, Mr. Chernoff.
Thank you, Judge.
Thank you.
Doctor, good morning.
Morning.
Please tell us what you do for a living.
I'm a physician.
All right. And do you have a particular specialty?
I do. More than one. I specialize in internal medicine, nephrology, and addiction medicine.
Addiction medicine. What is that?
It's the evaluation and treatment of people with addictive disease.
All right. Give us some insight into how you got involved in addiction medicine, please.
At one of the hospitals that I worked at, there was an addiction facility actively treating patients, and they asked me to get involved in seeing and evaluating and treating their patients in 1988.
All right. And so for the last 30 years, or 20 years?
23.
23 years, all right. You've been treating those with addictions.
Yes.
What is your background, medical background? You said it was internal medicine. When did you receive your medical degree? Where?
1974 to 1978, Hahnemann Medical College, Philadelphia, Pennsylvania. 1978 to 1981, medical internship and residency at Hahnemann University Hospital, Philadelphia, Pennsylvania. 1981 to 1983, fellowship in nephrology, Temple University Hospital, Philadelphia, Pennsylvania.
All right, let's talk about addiction medicine. What does addiction medicine encompass? What are some of the things that are, obviously identifying addiction is one of them, right?
Yes.
But there's much more to it than that.
Yes.
What does it encompass?
Again, it's broad. People come to me looking for help to stop drinking, to stop using drugs, and I assist them in comfortably stopping and in finding a therapeutic environment to treat the addiction and the underlying illnesses so that they can move forward in sobriety.
So if an individual comes to you with what is perceived to be a problem, you would address first, you would determine whether or not there is a problem. Is that right?
Yeah, usually when they come to me, it's pretty obvious. They're coming to me for help. Very rarely are they coming to me for me to assist them in making a diagnosis of whether or not they have addiction.
And this is they come to your office for that?
Primarily.
All right. Now, let's say an individual comes to your office because he believes he has a problem. What is the first thing that you will do to address that issue?
Complete history,
All right, and how do you do that?
Interview.
Okay. And could you give us some ideas about the questions that you would ask that person? What are you looking for in addiction medicine to determine whether or not, A, this person has an addiction, and B, whether you can help them?
But you're looking for drugs of abuse, you're looking for repetitive use, you're looking for long-term use, you're looking for comorbidities, you're looking for a history of age of onset, you take a history of all substances of abuse to find out what else they use besides what they're openly telling you. You take a history of adverse consequences of use, such as legal issues, social issues, etc. You look for underlying causes.
So you're going to take a survey of this individual. You're going to have interviews of this individual. Is that correct?
Well,
Both count?
what you would do is you would take really a complete medical history, but focus, aside from the routine, also on those aspects of addiction that are going to be important, because they'll present with a complaint: alcohol abuse addiction, opioid abuse addiction.
Now, on occasion, when people come to see you, do they come to see you denying any problem?
Occasionally, they're brought by family or friends or other referring agents in denial that they have a problem.
Now, what if this individual comes to you and he says, look, I don't have a problem, I don't drink excessively or use excessively, I don't have any problems at work or home? What would you do in response to that?
Again, you take a complete history, you develop an understanding of what they've been doing, what their behavior is, and consequences of that behavior, and then you try to enlighten them about the adverse consequences of their behavior. So, for instance, 2 or 3 DUIs would be an adverse consequence, even though it might not have been their fault.
What, if you were to take on a patient, now, do you take on any patient that walks through your door?
For the most part.
If they want help, you're going to help them?
Yes.
When you take on a patient and you've identified now that there is a problem, what do you do next? What's the next step?
I propose a treatment program.
Okay, now, the treatment programs, are they going to be the same for any type of addiction?
No, varied.
All right, let's talk about the types of addictions that you handle. What types of substances in the last 20 years or so have you handled that people were addicted to?
Well, let's start with alcohol.
Okay, that's a big one.
Common.
All right. And what are some of the things you look for when a person comes to you and says that they may have trouble with alcohol? What kind of adverse consequences?
Primarily legal, but also medical. So the obvious things we all know about: liver disease. So I'm gonna make sure I get laboratory studies on them to provide them further objective data to support my understanding. I'm going to interview them with respect, again, primarily to legal consequences and social consequences. Has it cost you your job? Has it cost you relationships? Has it caused you legal issues?
All right. Now, you also deal with addictions that involve illegal drugs. Is that right?
Yes.
Such as cocaine?
Yes.
Heroin, for instance, something
Yes.
like that? What about prescription medications?
Very common.
You say very common. How common?
I think the last data I saw were maybe 2.2 million persons in the United States, 2005-06, the last survey I saw, addicted to oxycodone and other prescription opiates.
What does when a person comes to you with prescription medication problems, does that provide you different concerns than you would have with alcohol or heroin or cocaine?
No.
Tell us what prescription medications would be, how a person who comes to you would get addicted to prescription medications. How would that typically occur?
Well, one way is prescription use. I mean, there's There is lots of iatrogenic addiction, but all of the
You need
drugs.
could you explain what that is?
Iatrogenic,
Yes.
iatrogenic, iatrogenic, and that means prescription that a doctor provided.
Okay. Now, is there a difference between dependence and addiction?
Yes, I think so.
Okay. In your opinion, what would be the difference?
Well, addiction, my definition of addiction that I like to use is a repetitive behavior pattern that can result in harm or illness to the individual, even loss of life, that continues despite adverse consequences. And dependence implies a physical need for a substance, but it's not a behavior pattern. And it might not be associated with adverse consequences. Dependence, for instance, might be an elective surgery that required a lot of pain medication postoperatively and resulted in a few weeks of opioid use, and then you might feel ill when you stop the opioid precipitously.
Have you, in your practice in the last 20-some-odd years, have you treated professional athletes,
Yes.
celebrities?
Yes.
And have you treated these individuals for prescription medication abuse?
Yes.
Now, when an athlete, let's take a professional athlete, for instance, let's say that he is injured, and he were to go to a doctor and get pain pills. At what point, in your view, would it become clear that that individual has developed a dependence on those pain pills? What are the symptoms? What are the signs that this has become a problem? That this has become a dependence?
It can be very subtle, but you would look for behavioral changes. You'd look for performance changes. You would look for use beyond the prescribed use, such as for sleep, for energy, for anxiety, particularly with a pain medication.
What about symptoms of withdrawal? Is that something you would look for to look to see if dependence has set in?
Well, if you have a withdrawal syndrome, that implies that there was dependence, physical dependence.
All right, let's talk about some specific drugs. You mentioned OxyContin. Is that, for lack of a better word, popping up quite a bit in your practice lately?
OxyContin abuse is fairly an epidemic.
Now, OxyContin is what type of drug?
It's an opioid.
It's an opioid. And there are other opioids in the same class of drugs as OxyContin. Is that right?
Yes.
Now, by example, let's look at benzodiazepines. All right?
Okay.
What's a benzodiazepine?
The classic and most commonly recognized benzodiazepine is probably Valium. It's a sedative.
And Valium came into being back in, was it the 70s?
I don't know.
Okay.
It's an old drug.
It's an old drug. But after Valium, other drugs, benzodiazepines, sort of branched off from Valium, and other benzos came on the market. Is that fair to say?
Yes.
Now, let's look at opioids. Am I pronouncing that right?
Yes.
Opioids? And we talked about OxyContin. Now, there are other, you said, opioids on the market as well. Could you mention those? Could you name those?
Codeine, Demerol, Dilaudid, fentanyl, Tramadol. There's a lot.
Let's talk about Demerol. How old a drug is that? How long has that been on the market?
From before I was in practice.
All right. It's an old drug.
Old.
And since Demerol, there have been other opioids that have come on the market.